My name is Kassandra Martinez-Aceves, and today I will be presenting on female sexual interest arousal disorder with a focus on mindfulness-based cognitive therapy as a treatment approach. So, Fsiad was introduced in the DSM-5 in 2013, and it emerged when we were previously two separate diagnoses. It was also known as hypoactive sexual desire disorder and female sexual arousal disorder into one. This change was driven by research showing that desire and arousal in women are deeply interconnected and often shaped by context, relationship factors, and cultural background rather than purely biological drive. In terms of how common this is, somewhere between 30 and 43% of women in the US report persistent sexual problems. Prevalence increases during hormonal transitions like postpartum periods, perimenopause, and menopause. What makes this especially relevant clinically is that many women never seek treatment, often because of shame, because their provider never asked, or because they believe what they're experiencing is just normal. Fsiad also frequently co-occurs with depression, anxiety, and trauma and is often overlooked as a primary concern. So, for a formal diagnosis, a client must be shown a marked reduction or absence in at least 3 of 6 symptom areas, persisting for 6 months or more. These areas include reduced interest in sexual activity, reduced sexual or erotic thoughts, decreased initiation or receptivity to sex, reduced pleasure or arousal during sex, reduced response to erotic cues, and reduced genital sensations during activity. Importantly, symptoms have to cause clinically significant personal distress, and they cannot be better explained by another medical condition, relationship problems, or substance use. That distress piece is key. Fsiad is best understood through a biopsychosocial lens. Biologically, we're looking at hormonal shifts, chronic pain, fatigue, and medication effects. SSRIs are a frequent culprit. Psychologically, spectatoring, performance, anxiety, negative body image, and trauma histories are common maintaining factors. And PTSD is significantly overrepresented in this population. Socially and culturally, relationship quality, gender role expectations, religious values, and internalized messages about female sexuality, they all play a role. One important note that I may add is Western models of spontaneous desire aren't universally applicable. Latina, Black, and LGBTQ plus women face additional layers of stigma and cultural context that shape how Fsiad develops and how likely a woman is to seek help. Cultural humility here means asking, not assuming, about clients' sexual framework. Mindfulness-based cognitive therapy was originally developed by Siegel-Williams and Teasdale in 2002 as a relapse prevention treatment for depression. It combines mindfulness meditation with cognitive behavioral strategies. Dr. Lori Brotto and Dr. Rosemary Basin adapted this model specifically for women with sexual dysfunction, grounding it in Basin's model of female sexual response, which emphasizes that for many women, desire is responsive rather than spontaneous. In healthy functioning, the treatment builds present moment awareness and non judgmental attention to bodily sensation. In disordered functioning, the problem is cognitive distraction, spectatoring, and avoidance that disrupts the mind body connection. Clinically, the protocol typically runs 4 to 6 structured weekly sessions, often in a group format, though individual delivery is also effective. Looking at this from a biopsychosocial perspective, biologically, hormonal and neurological factors disrupt the psychological arousal, with SSRIs being a frequent etogenic contributor. Psychologically, spectatoring and performance anxiety interrupts natural arousal cycles, and negative automatic thoughts during sex perpetuate avoidance. Socially, relational conflict, poor communication, and lack of emotional safety suppress sexual interest over time. MBCT directly targets the maintaining cycle, which goes distraction leads to disconnect, disconnect leads to avoidance, avoidance reduces arousal, reduced arousal increases distress, and that distress drives more avoidance. The group format also provides a normalizing effect that's really powerful. For many women, it's the first time they've ever talked openly about sexual difficulties. So, for assessment and treatment goals, from an assessment standpoint, routine sexual health screening should be part of every comprehensive intake, especially with clients presenting with depression, anxiety, or trauma. Two validated tools to know are the Female Sexual Function Index, or FSFI, and the Female Sexual Distress Scale Revised. It's also essential to assess for co-occurring conditions such as PTSD, depression, relationship distress, chronic pain, medication effects, and critically, explore trauma history before introducing body-based practices. Body scans can be activated for survivors of sexual trauma, so pacing and trauma-informed sequencing matter here. The primary treatment goal is to reduce sexual distress and restore interest, arousal, and satisfaction. Core techniques include mindfulness, meditation, psychoeducation on responsive desire, cognitive diffusion, sensory awareness exercises, and group processing. It is important to acknowledge that existing MBCTS research skews heavily white, cisgender, heterosexual, and partnered, so we apply these findings with cultural humility. For Latina clients, Marianismo may frame low sexual desire as a virtue, and stigma around discussing sexuality is often heightened. For LGBTQ plus clients, current models are built on heterosexual dyadic frameworks and need adaptation for diverse relationship structures and gender identities. For clients with Christian faith backgrounds, the key is to avoid assuming a monolithic view, explore what their specific beliefs in faith and community actually say. Mindfulness practices can be reframed excessively. Present moment, awareness as intentional presence, and body awareness as honoring the body as a temple of the Holy Spirit. From 1 Corinthians 6:19, addressing shame directly is also important, helping clients distinguish between value-based conviction and shame that disrupts intimacy. The evidence base for MBCT and Fsiad is consistent and growing. Brado and Besson's 2014 RCT showed significant improvements in desire, arousal, and sexual distress, with gains maintained at 3-month follow-up. A 2021 multi-site RCT by Brado and colleagues found that MBCT outperformed both an active control and a waitlist condition, with gains held at 6 months. Meditation analysis confirmed it was specifically mindful, non-judging, and non-reactivity that drove treatment gains, which supports the theoretical model. A 2021 meta-analysis by Mintz and colleagues looking at 11 studies found pooled effects across desire, arousal, distress, and satisfaction, all in moderate ranges. Limitations worth noting would be sample homogeneity, variability in protocol length, and limited long-term follow-up data. But overall, the empirical support is pretty solid. To wrap up, Fsiad is a treatable condition that clinicians are already encountering, often embedded within presentations of depression, trauma, or relationship distress, even when it's not labeled as such. Mindfulness-based approaches work because they target the cognitive and emotional patterns, maintaining the disorder, not just surface symptoms. Group delivery is practical and scalable in community mental health settings. Individual format is an effective alternative. Trauma-informed modifications are essential throughout, emphasizing choice, pacing, and control with any body-based practice. And cultural and faith-based adaptation isn't optional. It's central to ethical and effective care. The next steps for the field include routine sexual health screening, clinician training in mindfulness-based intervention, and ongoing cultural consultation. Thank you so much for your time. The full references are listed on this slide, including the key works by Brotto and Bassin, the MINTS meta-analysis, and the DSM-5. I'm happy to take any questions. Please email me if need be. Thank you so much.